Well, welcome everyone. Thank you so much for joining us tonight for what I think is going to be quite an exciting chat. If I can just ask everyone to please mute, make sure they're on mute. Okay. Right, my name is Romany Sutherland. I'm an attorney at Norton Rose Fulbright, South Africa. I specialize in medical negligence law. I'm also a director and branch chair of the South African Medico Legal Association. And I just want to thank Genoa Underwriting Managers who have agreed to partner with us and host this platform for us this evening. So Michael, John, and your team, thank you ever so much once again for joining us on this. Now, I don't want to take any more time. I was going to ramble on about the state of the country and our healthcare system now, but I think everyone's been brought up to speed in the media lately as to the dire straits in which we are right now. So what I'm going to do is introduce my dear friend and colleague, also a team member on that's South African Medico Legal Association, Elise Burns-Hoffman. Over to you.
Thanks, Romany, and good evening, everyone, and thank you for joining us. I'm delighted with our subject tonight, and perhaps a little selfishly so, just because I've had the privilege of working with Di Carson for some time as a consultant, and have even had the privilege of going up to Kenya to visit her at her offices in the last couple of years. And although Dr. Baer and I have met on email, we met tonight on Zoom for the first time. She's recently joined the organization in 2020. But I'm going to introduce Di and Dr. Baer, who will hand over the floor to in this Zoom forum. And let me just give you a little bit of background. So Di is a South African, and she was raised in Cape Town. But she's been resident in East Africa since 2006, when she very bravely moved to South Sudan to oversee the building of a hotel in Juba. And that was just the beginning of her bravery. So although she started her career in marketing strategy, management, business management, and so on, she moved into research, project management, training, logistics, procurement, all of which led her to become the divisional manager of Arden Risk and Support Services in Nairobi in 2011. So she moved from Juba to Nairobi. And it was through her work at Arden that Dada became immersed in remote sites medical support. And after some years with Arden, this organization, alongside some involvement with other independent consulting projects, she established ResponseMed in May 2015. So we're into year 6 soon. Oh, this is year 6. So ResponseMed has built a reputation for delivering quality medical support to a number of multinationals in remote corners of East and Sub-Saharan Africa. And we're very lucky to have Di in Nairobi tonight. Dr. Baer is in Somaliland, and Di came back from Ethiopia, I think, last week, and is off to Somaliland next week. That is how her life works, and Dr. Baer's. So in addition to the remote site work, the strategic support and development of sustainable medical facilities, first aid, and other medical health-related training that ResponseMed does in Kenya, Ethiopia, South Sudan, Chad, Rwanda, Somalia, and Somaliland, the ResponseMed team has had to pivot quite a lot in the last year with COVID. And in this time, they've done an amazing amount of work in developing and delivering COVID-19 policies, procedures, guidelines, and training across a vast number of business sectors: extractives, tourism, agriculture, renewable energy, NGOs, corporates, and medical sections in the sectors of the region. So Di is passionate about building capacity, delivering impact, and making positive changes in people's lives. And as I've already alluded to, she is a traveler at heart. And one never knows when one gets to speak to Di where about exactly she will be in the world. I've also spoken to her in France, I think, and in London. So she moves around. And I'm going to now introduce also the medical director of ResponseMed, Dr. Baer. And then we're all introduced and I can keep quiet. So Dr. Baer is from the Netherlands originally. and has worked in various countries around the world during her career today, 30 years of which have been in Asia and Africa. Her experience with working in remote healthcare settings and environments has given her an enormously deep level of understanding of the challenges encountered in providing medical services in extremely isolated places. And perhaps she'll share with us a bit later exactly how remote she is at the moment and where she's speaking from tonight in Somaliland. And alongside her medical experience, building and management of medical facilities, she's also helped to build a very large commercial business in rural Kenya, and she's worked specifically on environment, health and safety systems, on compliance with several international accreditation schemes over the past 20 years, developed corporate social responsibility programs in the company and in the community, and was instrumental in the development of the Human Resources Department of the organization, overseeing 1,400 employees. In short, Dr. Baer's professional skills and professional experience is actually quite limitless. And it's with this extensive skill set and experience that she's able to very quickly analyze the medical service requirements in remote locations, stretching across from needs on the ground to the specific requirements with regard to personnel, equipment, training, ongoing management, and of course, not forgetting diagnostics and patient management, just as an extra along the way. And she took on, Dr. Baer joined ResponseMed, as I mentioned earlier, in 2020 and is in the position of medical director. So now I very happily hand over to Di and to Dr. Baer. Thank you so much for joining us.
Thank you very much, Elise, for the introduction and for the opportunity to share some of our remote medicine insights with you this evening. I am going to hand you over to Dr. Baer, who's currently in Erigavo in Somaliland, and she is going to be walking us through her case study of hospital and farm capacity building in Western Kenya. Oops. So there we are. Baer, over to you.
Okay, well, good evening, everyone. I'm going to take you to this location that you see on the screen at the moment, and that is where the hospital is where I have worked for 25 years. It is in a very rural area on the border with Uganda in Western Kenya, on the slopes with Mount Elgon, and where you see the arrow, where that is where the hospital is. Okay, then we go to our next slide. This hospital is located 40 kilometers from Kitale town. Kitale is a town of about 100,000 people, very much in an agricultural area. But as you can see, the road to the farm and to the hospital was most of the year not even a road. It was more like a plowed field, and that really contributed to the isolation of the place. There were periods also with increased insecurity in the area, so travel, and certainly travel at night, wasn't always easy. When I arrived there in about 1995, there was really nothing in terms of healthcare in the whole area between Kitale and where the farm was. And the title of this talk is Africa, How You Respond. And well, we started responding by doing what we could under the circumstances. And my first delivery of a baby was actually in the garden under a tree with 6 dogs around me. And I said to my brand new husband, I cannot continue like this if I live here. So he agreed that we could use an old farmhouse as a hospital, as a clinic, and that's how it all started. Luckily, in 2007, we had the opportunity to bring in quite a big amount of donor funding. And with that, we bought extra land and we were able to build a new hospital. And at this point in time, it is like a cottage hospital with 35 beds, 40 staff, around 40,000 patients per year. the morbidity is the same as in most of rural Africa: malaria, respiratory tract infections, diarrheal diseases, TB, HIV. And there you see the amount, $375,000 per year. And if you kind of look at the patient numbers, that is to just below $10 per patient per year, which is not a lot. Okay, let's move on. This is the building. It is a very simple building. I designed it myself at the time because one of the things that I always found awful when visiting these rural clinics in Africa was the smell and not being able to breathe. So I designed it in such a way that there was lots of space, lots of areas for people to sit in. And we were incredibly proud in 2007 when we were able to open this in the presence of the German ambassador, because the DEG Bank from Germany was instrumental in getting this going. Can take another look. Yeah, when you start a facility like this, you know that you are going to run it on a shoestring, and that is difficult because that means that you constantly have to make choices, and choices usually, you know, where can I make the biggest impact and on the morbidity and the mortality, and what can I afford to try and achieve that. But this is still inside the hospital.
Sorry.
Yeah. So to be able to make those choices, you are constantly guided by these two questions, and all your choices need to be in alignment with each other. If one of them doesn't fit in, then kind of your whole system is not working. And one of the very basic things that you need to look at when you start is what is your beneficiary population. In our case, it was a population that was living below the poverty line, and yet we wanted to offer them a decent healthcare system, knowing that they themselves would not be able to contribute very much. And that there was a very low, this was 25 years ago, very low level of understanding of health and healthcare. Then how you design your building and how you build it inside is also very important for it to be able to function in the environment that you are in. So it's not fancy, and we need to keep in mind that all the people come in with clumps of mud on their shoes, and that in the dry season there's dust everywhere, and so it is very different from a clinic in an urban area. So you know that you're going to run it on a shoestring, and how are you going to make sure that you can keep going? It is an illusion to think that you can make a rural facility in the poorest area of Kenya self-sustainable from income from patients. So you will need to make sure that you have alternative sources of income. Now, with us, with this clinic, we were quite lucky that we had our commercial company behind us, because it was also in their interest to have a good health facility for the 1,400 workers in the farm. So the farm always contributed to the running costs of the clinic, which was around $10,000 a month in staff expenses. So at least we didn't have to worry about that. We had two small foundations in the Netherlands that were doing fundraising, and later on they partnered with a big co-funding organization in Holland. And with that money, we were always able to improve infrastructure, so build buildings and buy equipment. And the day-to-day running costs, so the cost of the drugs, the cost of the lab, and all the other day-to-day running costs of the facility were funded out of income from treatment from the patients, and later also from the National Hospital Insurance System. The choices that you have to make on staffing and equipment and treatment level are also totally directed by your income level in that population. So we could not even consider having a CT scan or anything fancy like that up to now. Well, I don't know what the future will do, but until now, those kind of that is all on a wish list. Then staff availability in a rural area is also much more difficult than in an urban area, and we have really struggled over the years to attract staff and to find staff that were willing to come and work with us for fairly limited salaries. And then still we were expecting quite good skills from them, and especially management skills. And that was not always easy. Supply chains, we organized that through a big non-profit medical supply organization in Nairobi called MEDS, and that has been one of the backbones of our operation. The relationship with the Ministry of Health and the government in a rural setting cannot be underestimated. You kind of want to fit into their system as much as you can, because you will need their assistance at so many levels, especially in the vertical programs for the program for immunization, HIV drugs, TB drugs, and all those vertical programs where you want to be able to benefit from the international donations towards the government. The referral system is also very important. You need to know what you can deal with yourself and where you can safely refer your patients. Now, in Kitale, we had a government hospital, a big government hospital with very poor resources initially, and there were a few private hospitals where they could do a little bit more in terms of surgery, but there were not very many specialists. There was no neurologist, no orthopedic surgeon. There was a pediatrician, but only one, and sadly he just passed away due to COVID. So that was still all quite limited. And then in the setting that we had, you can have everything in place, but if you have staff that are not committed to going the extra mile and really caring for our patients, then you can have all the equipment that you want, but your facility will not be thriving. And I have always been so lucky that we had a very good team of core workers in the clinic. Now we can move to the next slide. Yeah, so this is the kind of community that we were dealing with. This was earlier last year, where we went into a community and due to the economic suffering because of COVID, we found that there was quite a lot of children on the edge of malnutrition, and we had secured a big donation again from the DEG Bank for COVID. So you see the children here with Unimix, but if you look at the photo on the right with the those hands and feet of that child, that is not uncommon to see that in our area, and this was due to jiggers, yeah, it shows you the level of living standard in the area where we practice. This is then, you can almost call it a white elephant. This is our X-ray department. I bought this very expensive X-ray machine, and it was secondhand, but it was still expensive for us. And it was possible because of the donations from this came from Wilde Ganzen in Holland. But it was a big mistake. The machine was way too big, way too complicated, and it was very difficult to find staff that would come and work with us. So it took a very long time for this machine to give us the output that we had expected from it. So this was one of the things that was not in alignment with our situation. Go to, yeah, and then this is our team. Very proud of this team. It is a mixture of nurses, midwives, doctors, clinical officers, an X-ray technician, a pharmacist, lab staff, orthopedic workshop technician, physiotherapist, and then of course all the auxiliary staff. It's a wonderful team, and together they see usually over 100 patients per day, so that is quite a lot for this facility. Okay, challenges in this kind of situation. I already spoke about good quality staff, but also staying in the earlier years before internet and Zoom calls, it was extremely difficult to stay updated with CMEs and with CPD because we were so remote, and we would have to send staff, or I would have to go to Nairobi myself to attend CMEs. That was really difficult, and also because I was the only doctor, I had nobody to lean on, so I was trying to establish contact with colleagues, old colleagues in the Netherlands, but that is a real challenge when you work in a remote area like that. Nowadays, it is luckily a little bit better because of internet. To get the people to come to your facility and use it to an optimal level is also quite difficult, because the people who were near us, like the people that worked on the farm and the villages right next to us, they knew about it and they would come. But that community where we were in, where I showed the picture, that is 5 kilometers up on the mountain, and they already would not come to the clinic with things that could be quite easily solved. They would only come if things were already going quite badly out of hand. So now we are embarking on much bigger programs to draw people in and make them more part of our operation, and give them a feeling of ownership, because the hospital is built for the community and in fact owned by the community. But that took a long time to get that through to the local population. Another thing that was a problem over and over and over again, and I see it here in Somaliland as well, is technical backup and engineering backup. Because these buildings and these, like my hospital was a bit better, but also this one here, they are built also on limited budgets and by not very highly skilled staff. So you end up with buildings that need a lot of maintenance all the time. we were not on the electricity grid, we were not on any form of sustainable and safe water supply. So those things are a constant battle in a rural area. And then the biggest battle, the biggest challenge of that situation is for the medical staff, and also for me as the doctor in charge, is that you have to let your patients go at a much earlier stage. So when you know that if we had been anywhere else in the world, in the Western world, we could have done a lot more. That problem of having to stop treatment, of having to give up, of course, arrives always, also in Europe, also in South Africa. But for us, it comes that much earlier, and it is an enormous frustration when you have to decide that, no, I can't send this patient for a heart operation, even though you know even that in Nairobi they would be able to do it. The times when I have tried, and believe me, in the beginning I did try, because you feel incredibly guilty that you're not doing more. I sent a child for heart valve replacement. She came back. The operation was successful. We looked after her for a few weeks in our hospital, and then we sent her back home. Home was literally in a hut with parents who had no idea. And a few weeks later, she came back, and she had had an infection and everything had gone wrong. We had spent a lot of money on her, and she died. So that was again a case of not aligning my decision with our local situation. And there are numerous stories like that. I had a lady with neurofibromatosis, which really looked like Elephant Man, with a big trunk coming out, and she was not very old. And I really felt I needed to help this woman. And we got her operated, plastic surgery in Nairobi, and it was an absolute disaster. The woman had never been even to Kitale, so Nairobi was like going to the moon. She ran away from the hospital. We finally found her back and brought her back, and she wasn't grateful. The husband wasn't grateful. It was a total mistake to force that upon somebody, because we as the team felt sorry for this person. Big lesson again there. Let's look at our next slide. Yeah, if I look at the 25 years that we've been running this place, where we made very big steps in the development of our facility and progress in medical care. Of course, when we got that big substantial donor funding in 2007, we suddenly had a budget of 400,000 euros to work with, which was a phenomenal amount. And that made it possible for us to go from our little residential house, where we were it was bursting at the seams, into this lovely new hospital. That was a very big step and a very big sign of hope for the community as well. I would say, and this is maybe interesting because this is now a talk with an insurance-based audience, when the Kenyan National Hospital Insurance Fund started to function properly, that really propelled us into a situation where suddenly we were able to claim for most of our patients, where we were able to increase the fees slightly. And that is what made the hospital suddenly arrive at a much better cash flow situation, and we were able to run the hospital. And from then on, we were almost able to run it without donor funding. And that was what we had been working for all these years. Bringing in modern equipment in the lab, the X-ray machine, our flagship program was the orthopedic workshop, made a big difference in how we would be into the quality of the treatment of the patients, let's put it that way. We acquired a proper ambulance in 2012, so it became much safer to take people to Kitale on that terrible road. Another very big moment in the life of the clinic was around 2005 when PEPFAR donated the ARVs for HIV treatment to so many African countries, and that made it possible for us to start our HIV/AIDS program, and we have been running it ever since. We have full documentation for those 15 years. We were running mobile clinics for HIV in the community. We got more funding. We built a big comprehensive care center, and I think at the moment in our area we have over 1,000 people on ARVs, which may not seem like such a big number now, but at the time when we were pioneering in 2005, this was really a very important program. In 2018, we were invited to take part in a big accreditation audit, and that really helped us to improve our own standards in the whole clinic, and to keep adhering to those. And last year we did an introduction of the of an automated hospital management system, and we feel that with that we have finally arrived in the modern world of medicine, where we are now able to link everything to make sure that the systems are managed, especially our drug stock system, but also to have the patient information at hand. And so we feel that we've come a long way over those 25 years. If we look at our most successful activities, it's got to be the mother and child healthcare. A few years ago, we got another donation from a family who had lived in Kitale for a long time, and they left a legacy to us, and we built this pediatric ward with that. That next to that you see a child with terrible burns. We see a lot of those due to malaria. We get seizures, and children fall into fires all the time. This is a little baby, probably burns by hot water from tea. But the mother and child care is really one of the areas where we have been able to give a lot of assistance to this community. HIV/AIDS Center, I've already explained about that. And our orthopedic workshop with a program where we select patients for orthopedic operations, but we also make prostheses and wheelchairs. This is one of our teachers, an ICT teacher, and his disability is polio related. But we got him a new wheelchair. But this was a program where we have also helped thousands of people over the years. I'm looking at the time. I will quickly take you to maternal health care. I think with the maternal health care, the key is to leave no opportunity unused to inform people about antenatal care and family planning, and get them into that antenatal clinic. Once you've captured them there, then they will usually come for safe delivery in the hospital, and that is also supported by the Ministry of Health, because they with their hospital insurance fund, they pay for all the deliveries in hospitals. There is a link with the PMTCT program, where linked to the HIV program. PMTCT is transmission from mother to child. You get them then into your API program for vaccination, and you get them into the family planning program. So once you can get them into your antenatal care, for me, that is the key to your mother and child healthcare. When you deliver mother and child healthcare, it is very important what kind of atmosphere you create in your clinic. Is it friendly? Is it understanding? And so again, this comes back to how committed is your staff to paying attention to the patient. In Africa, there's often, especially in the government facilities, an inertia in taking action, and when you have a little center like ours, that you normally work with a team that is much more committed, and that is often instrumental to the success of your facility. Next slide. This slide is then also important, because your healthcare facility in a rural setting is not a standalone operation. If you were just to focus on healthcare, you would not see any difference in the development of an area. So it needs to be part of a bigger setting. You need to be in touch with schools for education. You need to be in touch with agricultural practices for nutrition. If there is an opportunity to improve housing standards and better sanitation, that will have a tremendous effect on the general well-being of the people, just like it did in Europe when they started bringing in sewer systems and children were going to school. That same principle will apply here as well. So if we take a look at the last slide, then we see that same picture that we started with, and we pointed out where the hospital is, but next to the hospital you also see the school, the secondary school, a vocational training center, an orphanage, and on the other side of the road is a big social housing program, where the people have stone houses with a stone floor, with a proper toilet, with piped water. And in that community we have seen, and they all have a garden where they grow vegetables. And in that setting we have seen an enormous improvement in the health status of the people, and an increase in the level of standard of living. I could go on for a long time about this whole setting, but for today I will leave it like this, and I will hand it over to Di, and thank you for listening.
Thanks very much, Bea. So now we're going to move on to a different kind of remote, which is one that I'm more familiar with. And really, I'm not sure how many of you have that much insight into the remote site health space, particularly within the private sector. But historically, ResponseMed has primarily looked after companies in the extractive industries, renewable energy, infrastructure development, tourism, all of whom are working very remotely in countries and in areas where there is no medical support. So we set it up for them, but a lot of that support is obviously trauma support, because we need to stabilize and package people before we move them on to the next point. So I thought I would just start off by showing a couple of visuals of the kind of remote sites that we've looked after, to give you an idea. This is one in Ethiopia, which was for an exploration, seismic exploration company looking for oil. The two on the right are in Kenya, in Turkana, where there was oil drilling activity, the visual on the bottom right, and the kind of environment that our medics were working in were containerized clinics, and together with obviously 4x4 ambulances. This is a rig site that we looked after in Chad for 3 years. Sadly, COVID and the events of the last week might impact on when this one gets going again. But this is a 12-hour drive from N'Djamena through the desert, and the airstrip hadn't been approved by civil aviation, so we had all sorts of challenges when we had to pack people up and get them out of there. This was the clinic on that site. That's one of our Chadian medics. The double crash doors to access the clinic, and then obviously we can make the clinic support to whatever spec we need to. On the extremely remote sites, we obviously have a very high trauma spec offering. So Bea is in Somaliland tonight, and we wanted to touch on this project a little bit. Some of her learnings of the last 25 years are being repeated, as they often are. But Somaliland, you can see, is the Horn of Africa, and we're working in an area called Sanag in Erigavo. And as you can see on this map here, here's Hargeisa. This is the capital city that we fly into, and then we drive. We drive for 2 days. We can't drive at night because it's too insecure, and so we hit the road. But rumor has it that there's going to be an airstrip opening before too long. Anyway, the reason why this particular project was chosen, a foundation who do commercial work in the area as well, their main company, identified and researched the lifetime risk of maternal deaths being one of the highest in the world, and very, very little access to MCH healthcare as a result of personnel, ill-equipped facilities, and poor supplies and medication. So what we did as a team is we went in and we, in addition to talking to all of the NGOs and development agencies and the Ministry of Health, we spoke to the community. We got their insights into their health issues, their insights into how many babies they had lost along the way. Every woman in this group had lost at least one child. We spoke about their lack of trust of the healthcare system and what would instill trust and what they wanted to see focused on. We also sat under many trees with community elders to get their insights and their perceptions around what was needed from a healthcare perspective, and they were very supportive of more maternal child health support, as well as trauma support, road traffic accidents and the likes, as the road infrastructure is finally starting to improve. There's nowhere to go for a trauma case. And the photograph on the left is the hospital in 2018, and this picture was a couple of months ago, and we open officially next month. Bea is there, buttoning down many things on a daily basis. So just a few challenges that we have in our game. We work in a number of countries. Every country is different in terms of licensing approvals, permits, how we get our licensing to work there, various levels of bureaucracy. In some countries, I have to say Chad and Ethiopia have probably been my most two challenging on the sort of the amount of paperwork processing that one has to do. We have varying customs and duties, and unfortunately we're all aware of the fact that there's also much corruption on the continent. So we have those issues to deal with. Quality of local pharmaceuticals. If it's not the real thing, it's substandard or counterfeit in some way. And in the region, they estimate that 1 out of 4 meds sold over the counter are substandard. So we have to be very strategic about where we buy our medication from. Bea alluded to working with Meds in Kenya, who we actually procured all of our medication from in this visual on the bottom left. And that's because they second to South Africa, have a WHO medication quality lab checking the quality of medication before they take it out to market. So our first shipment of drugs for the Somaliland hospital came from Meds, obviously presenting logistical challenges. It took 6 weeks to get there, and then 5 days to unpack the boxes and have them cleared. And then it had to hit the road, which looks like this in dry season, or like this when it's raining. So, yeah, we perennial logistical challenges, which keep us not bored. I think the other challenges that we have, and particularly on the more remote sites where we're working with communities who have not had much exposure to anywhere else in the world or the capital cities of their own home countries. Essentially, they are hosts, whether we're going in with a renewable energy project or a exploration project. So the upfront relationships created and perception management created with all communities is absolutely critical to the success of any project prior to it even breaking ground, and then obviously the ongoing management of expectations, as well as providing communities with access to, obviously in our space, to healthcare, but to all of the other points that Bea raised in terms of the bigger picture. And I think the challenge that we have on some of our more remote sites, particularly in the more insecure parts of the region, is there can be a policy where community members are not treated at these remote sites, which are sort of isolated. So, but obviously we wouldn't turn anybody away in the event of an emergency. So it's also managing this facility is not here, it's a rig site. We don't even offer our staff within the rig site primary healthcare, so we're not offering it to anybody else. It's here for emergencies only, and managing those expectations. Obviously, when there are emergencies, the sites do accommodate them, but that's a challenge in terms of getting the balance right. This particular photo is on the shores of Lake Turkana on a renewable energy project that we're working on there. And I think that they're doing amazing things within the community on so many levels. And I think there've also been a number of learnings along the way in terms of, you know, one of the challenges that we had was the client established and built and set up a community clinic very close to the main site, and supplied water and power and everything else that it needed to operate. And the understanding was that once it was completed, would be handed over to the Ministry of Health for them to staff it and manage it. And the clinic stood empty for quite some time because it's also very difficult to get staff to go and work there. They're working in quite a hostile community. They're of a different culture. They're completely isolated. And And so what we've more recently done is we're working closely with that clinic and supporting that medic as and when required, and integrating him into our community a little bit in order to make sure that we have some longevity. But it's amazing to see how busy that clinic has become. Elise alluded to some of the COVID training and awareness that we're doing. We're rolling out ongoing programs in 5 countries. And I think the biggest learnings are, surprisingly, one of those countries is Tanzania. So needless to say, the perceptions coming out of Tanzania are very, very different to the ones coming out of Kenya and Uganda and Ethiopia and Zimbabwe. But I think in terms of stigmas, we've found that the stigmas vary from country to country. The way in which that they are communicated within the community. So a lot of the work that we've done is on remote farms, fruit, veg, and flower farms. And it's about talking the same language as the people we're talking to. So we've developed all of our material in vernacular. We've developed AV clips in vernacular. We've trained trainers to roll it out to their workforce. And we're currently doing some follow-up training for them on vaccinations and perceptions around vaccinations. So yeah, a couple more challenges. Just in terms of, obviously on our remote sites, we're all about health and safety because we have to mitigate risk as best possible in order to ensure that nobody needs to come to the clinic or no one, we don't need to medically evacuate them out. So we have a lot of very good medical professionals who have also been flexible and open enough to take on a health and safety role on our sites, where they work with the health and safety management team to mitigate risks. And these risks can be anything from, we're very remote, so tonight's supper was slaughtered at lunchtime today, and it needs to obviously be done in a hygienic way, and then we need to make sure it's transported appropriately and stored appropriately. So overseeing the slaughtering of some of the animals. We also, it's amazing how wherever there seems to be any mineral wealth, we have the world's most venomous snakes. And we do have some very stringent snake treatment protocols for most of our sites. And we have a particular renewable energy site in Kenya who are in the coastal province where they have the top 3, the worst. I mean, we get daily updates on our WhatsApp group of red spitting cobras, puff adders. We've seen one mamba. So on this particular site, we have a dedicated snake handler. We work very closely with the Bioken Snake Farm and East African venom suppliers to support us with identification of snakes and management of bites as and when we have them on site. I think we've done about 4 snake bite medical evacuations to date, and I don't really want to do another one. But obviously we need to the skill set of our staff needs to be a trauma one. And I think what we are finding, particularly in the East African region, is as soon as a number of the nursing professionals are trained into the critical care nursing space, and a lot of the doctors pursue more trauma life support skill sets and emergency physicians, is they get snapped up by the rest of the world. So we are experiencing a big brain drain, as I know South Africa is too. What we do, our level best to do is look after our staff. These sites are remote, you can't get out of them, they're quite contained. In an ideal world, we do 4-week on, 4-week off rotations where they have a back-to-back so that they can come home for some normality. And we never really like our teams working for more than 6 weeks, given the challenges, and obviously a lot of people got stuck in COVID. And I know one of the doctors who used to work with us got stuck in Kabul for 8 months as a result of COVID, as so many people did. Not something we would recommend. So I think that the other thing that Bayer also raised, but some of the places we're working are hugely insecure, which is why they can be very confining in terms of movement. Bayer's got 3 guards returning to the guest house with her tonight from the hospital. They stick to you like glue, even though neither of us feel particularly unsafe in Somaliland. I think there are other areas where we do have insecurities. We were recently supporting a gold site in northern Ethiopia, in Tigray, and sadly that one is now also on hold because of the insecurity in the area. Medical emergencies and medical evacuations are obviously a large part of what we do. They are never the same. There's always a new learning. I think everybody thinks that they're a whole lot easier to facilitate than they really are. We've had so many learnings over the years, you know, where because it might take an hour and a half to fly from a site to Nairobi, the perception is that someone who needs medically evacuating can be back to Nairobi in 2 hours, but it doesn't necessarily work that way when you take the insecurity risks into account, or there are many areas where you can't fly at night, not only because of insecurity, but also because of wind. So end-to-end evacuations can take a considerable amount of time. You can have issues with community being very interested in airplanes arriving because they've not seen one before, or you have issues where we need to do wing-to-wing transfers because the site is not accessible via fixed wing, as well as having to stabilize patients for long periods of time before you get them to a reasonable center of care. So yeah, perennial learnings. We've done 3 COVID medevacs out of Ethiopia in the last 2 weeks, and from the approval of the first one to the aeroplane taking off took 26 hours. For all sorts of reasons and very many moving parts. So it's never a quick fix, and I'm very grateful to our Ethiopian team for having had lots of oxygen in Addis over this period. So just getting to the CSR of what our sites and our clients and what ResponseMed does too. Bayer's touched on some of it. Obviously, it always needs to be needs-based and needs-driven. Is the infrastructure development appropriate? So particularly in the more rural setups, overspecking an oxygen system or overspecking water systems, inappropriate the more remote you go because you don't have the expertise. The infrastructure of facilities in terms of building, plumbing, wiring, it's worth, if that expertise is not there, it's worth investing in it to make sure that we get the foundation right. And then what we see a lot in the donor space is a lot of the equipment or contributions to support can be too technical. So something will be donated. We do masses of facilities audits everywhere, and I see the most amazing equipment sitting outside the facility because no one knows how to use it. We also see clients buying all of their kit from the US, and it gets to Africa, and for us to get a spare part or that kit calibrated is near impossible or has huge impact on timelines. So we always look and see what's available in what country to be able to make sure if possible, that we can calibrate and service and supply parts as quickly as possible. So I've alluded to enhancing facilities and keeping with capability, skills development key. I think that is going to always contribute to any area. And what we have done on some of our projects is obviously shadowing programs, and we've upskilled ambulance drivers to be basic life support and then to be in the back of the ambulance. So upskilling as much as possible. And then obviously coming up with sustainable solutions. Again, when we go in and we do audits of facilities, we find, and there are a couple that come to mind where we find the ministry asking us to support or to provide finance to support a mobile clinic that started off its first 3 of its 5 years very, very successfully. And then since that initial donor funding dropped off, so did the mobile clinic. And can we get it going again? And can we staff it? And can we fuel it? And it's really realistically looking at how long one is going to be there for, what you can contribute, and what players you can work with should you then move on from that area. Who's going to help you make it sustainable and support it and realistically make it a success. And I think a lot of corporates want results quite quickly, and so sometimes it's a little bit of a flash in the pan concept, but actually we work much more closely with everyone now in terms of sustainability and making sure that we get it right, because it's in everybody's interests to working with the Ministry of Health and collaborating with all players is an obvious one. We recently reached out to a few players in Somaliland on what they're doing in terms of the increasing COVID in the region, because we don't want to be going to reinvent the wheel. We want to be doing it together, and we want to make sure we've got it right. So on that note, just last week, we had a couple of biomedical engineers in Somaliland. One is permanently there, the other one had come in for a pre-opening equipment check. And the Ministry of Health received a small oxygen plant that they didn't know where it had come from, and they also didn't know how to install it. And the oxygen supply in Somaliland, I've been to this oxygen plant in Hargeisa. So for us to refill our cylinders would be probably a 5 to 7 day turnaround time once we've got it on the road, offloaded it, filled it, got it back. And so it obviously makes sense for all of us to work towards increasing oxygen capability, which is happening. And we worked with the Ministry of Health very quickly to get this oxygen plant up and running. And that came out of conversations with them in terms of what can we do to support each other through COVID, as well as many other initiatives. So on that note, I'm going to say thank you. And thanks for the opportunity to talk to all of you.
Di and Dr. Beyer, I'm kind of overwhelmed by your bravery, and you are the epitome of superheroes as far as I'm concerned. You really are. And it's just, you're walking angels, and I know there's a lot of people who could only dream of doing what you do, or just helping the number of people that you do help. And I think it's absolutely extraordinary, and I feel quite honored to have listened to your story this evening. So thank you both very, very much. I want to open up, if it's okay, for a couple of minutes to the audience for a couple of questions. I know the one was with regards to litigation. I guess in order to have litigation, you need lawyers, and it sounds like there aren't many of those around there. But do you see any sort of medical litigation?
So Bear, you can answer that and then I'll follow.
Yeah, in my situation, it did happen. We did have ambulance chasers in the area in Kitale, and that was always a bit tricky. Maybe not even so much at the hospital itself, but for instance, if there were issues with health and safety in the company, or if there was an accident, that at that point there were always people wanting to step in and represent the person, and yeah, so it is an issue in the hospital. There have been a few instances where people could have done something, because of course over 25 years you do make mistakes, it's unavoidable, but that has luckily never happened. But it won't be long before that will also start, I think.
I see we've got a hand up from Maxwell. Maxwell, if you can unmute yourself.
Okay, good evening, everyone. And I just want to thank Diana and Bear for the wonderful, great, amazing work they are doing. I can identify with some of the challenges and success stories that they are telling. I'm a neighbor to the Turkana. I work in East Pokot, and talking about insecurity, talking about the level of education of the people, the challenges that are there, I can understand with you. And so I feel very encouraged that we have similar stories, and then we are not giving up, but we are pushing ahead. Particularly, we are much involved in maternal care, and talking about referring the patients to, mothers who are in labor to a very long distances on bad roads is a story that, you know, when you are able to succeed, you can really rejoice. So I really want to share with you and to thank you for the wonderful job you are doing. We are also feeling very encouraged by your stories. Thank you.
Thank you.
Thank you.
Thanks, Maxwell. Anyone else, if they want to put their hands up or just unmute yourself and ask a question?
Romany, I'm sorry I had to dash out, but did this question get asked? Did somebody read out the question on the chat about the consent to the procedure that Dr. Bayer spoke about? Was that mentioned?
No, we haven't done that yet.
Okay, so Harriet says, this is amazing work. Just a question. When you say the patient who was operated upon was not happy, it didn't show appreciation, I wonder who consented for the procedure, and did they understand what was to be done? Dr. Bayer?
Yeah. This was a long time ago, and I did have several sessions with the lady and her husband, and the husband was like 40 years older. We went through the whole procedure. I think at that time, I didn't understand yet how they didn't understand what was going to happen. And I would never do it again now. But at the time, we were all in agreement. It seemed like a good idea. And the operation was also successful. She looked much better. But what I didn't realize at the time was that she wasn't all that unhappy in that situation. And to the husband, it also didn't make a big difference. So that was very much a cross-cultural misunderstanding. I don't think she was harmed by it. I don't think she was extremely unhappy with it. But I think the whole procedure, from having to go from the little village where they lived all the way to Nairobi, having this operation, it was just too overwhelming and too much. And I would never make that choice again now.
I think
sorry, you go,
Elise.
Romney.
I think, you know, it's such a vitally important learning curve that, and as you say, you know, things get lost in translation between the different cultures. And so I thank you for telling us that story, because I think it's vitally important. The one thing that I'm really took from this, I am involved in a lot of fetal maternal cases where there's a brain injury due to a birth defect of sorts. So, and what you said about focusing on antenatal care, and then usually, you know, you educate, and then the rest sort of falls into place. I think that's vitally important, and it's something that I think, Elise, we should, you know, as a team also look at trying to educate and convince our public health sectors to maybe focus on, as something that we should really focus on. But
absolutely. I mean, one of the questions, I had a whole host here, but one of the questions well, there were quite a few. So, Dr. Bayer, one of the things I thought might be nice to explain, you showed us that road to Kitale, and you said it's 40 kilometers, but maybe that guy mentioned the 12 hours in Somaliland. How long does it take to do that 40 kilometers to get from your clinic, your hospital, to Kitale Hospital? So I think that puts it in perspective, if you could say what the time period is to get across that road. She's frozen.
yeah, it looks like it.
I think Dr. Bayer froze. Oh dear. Okay. Well then, Di, I had a question.
I know now it takes 1.5 to 2 hours to get from the farm to Kitale, but I suspect 25 years ago it took a lot longer.
I think that's one of the things when we talk about rural and Africa, is that many people don't really, well, they can't appreciate the how long it takes to move, because 40 kilometers from where I live in Cape Town to the city centre takes maybe 40 minutes. Whereas, you know, out there, it takes so much longer, and that delays everything in terms of health. But one of the questions, Di, that crossed my mind when you were talking about community and how you spoke to those ladies who've lost a child and to the elders and so on, is what does instill trust? Because I can imagine when there's a cultural difference and there's these people coming to do things that are maybe foreign, what is it that actually instills the trust that you referred to?
I think a lot of the lack of trust coming out of the community was a result of how the health care offering had deteriorated over an 8-year period. So in 2012, up until 2012, MSF were very active in this part of Somaliland, and they pulled out because of insecurity. And sadly, as a result of that, things deteriorated. I think given the real remoteness of the facilities there, and also because of the insecurity, a lot of the NGOs and development agencies are actually not allowed to go and see their projects. I think it will change now that the infrastructure is improving and that there will be an airstrip. But so there were a lot of projects that were running on donor funding that weren't being audited. And I think with that, there was a further deterioration to the point where a couple of the community members said to me, there's no point in us even going to the local clinic or facility because there's never anybody there. Last time I took my child, I waited for 10 hours before somebody appeared. So it was a community that had better healthcare and then watched it unravel over a few years. And I think that it's a community that is also very, very talkative. So if there's good news, everybody will know, and if there's bad news, even more people will know. And so it's about managing perceptions. It's about communicating what we can and can't do. But I think there's also a perception that because we've come in with trauma equipment and trauma specialists and remote site surgeons, there's already a response to you're bringing us more than we've had. But it's up to us. The challenge now is for us to reinstill that trust and to follow through with a consistent offering, and to follow through and focus on the things, you know, to Bear's point, making choices, focus on the things where we can make a difference quite quickly, and continue to change people's lives.
Amazing. There's another question that's come up. How do you manage, thank you for that, I mean, very insightful answer, by the way. How do you manage with a terrorist group very active in the country? That was Prof. Stellenberg, who's in Port Elizabeth. She asked that question.
I think we, and this is where, if you're looking at Somalia, and Somaliland is a self-declared independent state, which is not internationally recognized, but it's a very, very, having been to both, it's a very, very different country. And before we chose to go in as a team to support this project, given what we do, we work with a number of risk advisors and consultancies. And I spoke to a number of Somaliland experts who I listened to, and I'm very grateful I did, because Somaliland is not that tricky. I think we do require military escorts, which is a requirement from the Ministry of Defense, but yeah, I think every country we tread cautiously if there is insecurity, and our clients have risk professionals behind them, and if we're comfortable that the risk offering is going to enable us to do what we want to do in the best possible way and in the most secure way, then we make that call as to whether we're willing to go in ourselves. I've always said I would never send a medic into somewhere I wouldn't want to go. And there are a few places that I wouldn't want to go to. So, so I had no problem asking Dr. Bear if she could go to Somaliland.
Well, you've done it a few times now. So there's some lovely comments. Life is so rewarding when helping those in need despite the challenges. Somebody who must know you, Cecilia, she says, oh wow, when you worked at UNSOS compared to this, looks like a whole new life. I'm amazed. Lots of thanks so much, amazing, inspirational. Some fabulous comments here. Are there any more questions? I think we've lost, I think Somaliland's lights went out.
No, Bea's back. She's back.
Oh, she's back. Oh, okay. I just can't see her. Oh, good. Any other questions from our attendees, our group?
Trying to see if there are any hands up. Doesn't look like it for now.
Well, if anyone's got any questions, they're welcome to send them to us.
How should, if people want to, I don't know, contribute or donate, help in any way, if we have some sort of a nurse here who's been inspired and she wants to join you, what do people do? Do they go onto your website?
Yeah, and Elise has got my email address and contact details. So anyone who wants to follow up after this, they're very welcome to get hold of me.
So Romany, you're coming to Kenya with me next time.
Oh, absolutely. No, gee, wow, it's just incredible. It's such an inspiration, and I know that it's not easy, and it looks it looks, you know, some of these places look like hell on earth, and I'm just flabbergasted by what you guys are managing to achieve, and it's so super. And now, also in terms of South Africa, do you guys ever come down south? Can we host you and spoil you with wine and dine you anytime?
We look forward to that. And I'm
for sure.
from Cape Town. And so I used to come a little more regularly. And my mum lives in Cape Town, but happens to be in Nairobi. We whisked her away. And she's had her first vaccination and waiting for her second one. So I'm hoping to come second half of this year when things ease up a little bit.
Well, that would be lovely. We've got a lunch or a dinner, and whatever you need, wine farms, we're going to spoil you. So
I'm sure we'll have no problem luring Bayer.
Yeah.
Oh, I look forward to it. Maxwell raised his hand. Maxwell, do you have a question?
This time not a question, but to say that the next time you are coming to Kenya, consider East Pokot as one of your destinations, because we have a lot of common things to share, and you'll be happy with it.
I love Kenya, and I used to complain about the traffic in Cape Town, but then I spent some time in Nairobi, and I think the traffic in Cape Town is a complete light. It's completely nothing in comparison to Nairobi traffic.
Maxwell, please reach out to Elise to get my contact details so we can be in touch.
Okay, thank you so much.
Right, thank you.
Yes.
I just wanted to ask just one last question, if I may. With regards to COVID, we don't hear much about Africa and what's happening with COVID up in Africa. What is it looking like compared to the rest of the world? Where do you guys stand?
Who wants this first, me or Bayer?
You can answer.
Well, I'll say a little bit, and then Bayer can follow on. I think we had a very in the region we had a very limited first wave, and everybody's talking about a third wave. But in terms of the kinds of waves we've seen in the rest of the world, I would say we're going through. Well, it is our third wave, but it's more like a big second wave, and we are seeing critical care beds in the region overflowing. There are not that many of them, so where you compare Nairobi and Addis and Kampala to the likes of Cape Town and hospitals in Europe, I mean, our critical care beds are between 50 and 500 probably across the capital cities per city. So yeah, we're falling over. We are seeing increased awareness and prevention measures in place. I think everybody is taking it quite seriously. We do see the positivity rate come down as soon as more measures are put in place in terms of intercounty travel or curfews. Sadly, we've all lost colleagues and friends in the last few months. So it is on the up. But and when someone says, so what's it looking like in Nairobi? And we say, well, we had in the last week, I think we've had between 900 and 1,300 cases a day, ranging from 9.5% positivity to 16%. Everyone says, oh, but that's so few cases. But we're also not doing an enormous amount of testing like other parts of the world. I think you see huge success stories in Rwanda, a smaller country. They've also been very impressive with their vaccination rollout. Kenya's been pretty good at its vaccination rollout. But yeah, we're just under-equipped. We don't have the critical care skill set, and we are seeing an increase and hospitals stretched and are all of our medical heroes really struggling and falling over. I heard today on the World Health Organization Africa call, some of the team participated, and they've identified a few African countries where vaccinations have actually expired, one of them being South Sudan. So WHO said today, continue to store that stock appropriately and in the right cold supply chain, and we will come back to you in terms of what to do, but don't discard it, because we all know that some meds can last longer than the expiry date, but they're obviously having a conversation around that at the moment in terms of what the responsible thing to do is, particularly when we're in such short supply. Tanzania is our most interesting case study, and we're actually delivering some training there tomorrow, and we tend to get more insight out of the training we deliver than we do out of any of the statistics coming out of there, because it's not being reported. It's pneumonia.
Oh, my goodness me.
So,
Interesting.
So yeah, it's definitely there. I mean, last time I was in Somaliland, it was a lot more, the awareness and prevention measures in place were significantly greater than 6 months ago. So I do think everybody is taking it more seriously.
Any more questions or comments, anyone, before we draw to a close? This is somebody just posted something in the chat now. I'm sure that those working in resource poor conditions under trying circumstances have a lot to teach those who work in increasingly restrained contexts. The blame for poor medical care is often placed on the lack of resources, but it seems that the emphasis should be on the word care, not resources. That's an interesting comment. Yes, I like that comment too. And I think of what, you know, both Di and Bear, but Bear talking about your engagement with your staff and getting the right staff and personnel, and difficulty in working in isolated circumstances. And it speaks to a lot about the communication and relationships with the people and the care, rather than just the resources. Absolutely. Thank you so very, very, very much, Bear and Di. It's been tremendous. I'm sorry I had to disappear and missed a few questions, but it was really a most amazing webinar. And thank you so much for your very valuable time and sharing your insights. And oh, we've got a hand up. George, would you like to say something?
Yeah, good evening, ladies and gentlemen. I'm really delighted to see how you're moving to greater heights, and being ladies and your artists, it's really inspirational. I'll tell you to keep going. At least I've been in touch with Di every now and then. He's a good boss, and she's a go-getter. And the same thing with bands. I'm really happy. The Kitale story is inspirational. It really puts a lot of weight on us men to really try and catch up with you. Yeah, paces ahead, going to places where most of us really are looking forward to. But I'll say it's a big thumbs up. Don't think it's not intimidating, it is. I'm happy for you guys. Keep it up. Thank
you, George, very, very much.
Thank you, George.
Thank you for keeping our remote sites going so well.
I'm grateful. Keeping going. That is you. Thanks to you.
I suspect Bear and Di, you might have recruited about 50 other people tonight, by the sounds of things, and looking at all the comments.
Very good.
Just want to tell everyone that this has been recorded, so if anyone needs a copy and would like to watch this, I'm going to definitely watch all of this again to try and absorb it more and more. It's just so incredible. So just ask any of us at SAMLA and Genoa with Elise and at Norton Rose. And there's also a CPD or CEU point that you can get. Like Genoa is assisting us with that. And so those of you who have attended will get that. But thank you very, very much once again, ladies. It was just incredible this evening. I've been looking forward to it for ages, as I know a lot have. And Elise, I really approve of the company you keep, my dear.
Thank you. Yes, so do I. Thank you. There's one last comment to close off with, which is lovely. Thank you, Frida. Thank you so much. Wow, you're doing such a great job. Thanks. We salute you. And I think that's a lovely way to end the evening. So we do indeed salute both Di and Bayer for the amazing work that you do and so many lives that you touch in so many countries in so many different ways. Thank you so much.
Thank you very much for the opportunity. We look forward to seeing you here before too long.
We do too. Okay then.
Good night, everyone.
Good night, everybody.
Good night.
Bye. Bye.
Bye.
Bye.
Thank you so much. Thank you. Bye.
Thank you very much. Bye.
Bye. Bye. Yeah, it's done. Thank you.